Hi, everybody. You are listening to Judging Meghan with your host, Meghan Judge. I'm wearing my glasses. I just got them filled. My beautiful guest is also wearing her glasses. And I spend a lot of time, Dr. Shah, talking about how much I hate glasses. I mean, the podcast there's probably like 55 episodes about me talking about glasses, but I'm embracing wearing them on YouTube because I'm just so vain. And I just have to own that I have to wear glasses and I'm getting older.
These are really cute glasses, I have to say.
Well, yours are cute too, by the way. We've all been put here for a reason, and we all deserve acceptance.
Judging Meghan with Meghan Judge.
I'm a trauma survivor from a really young age, and I have been diagnosed with complex PTSD in the past few years. I've been surrounded by death and abuse much of my life. I've been dragged through the mud and have been to the point of not wanting to go on anymore. Through my interviews with other survivors, I've learned that there is a way out. From recovering to surviving and thriving, we all have the strength to come out the other side.
You are listening to Judging Meghan.
I am just going to get right into it. So Dr. Shah is and I should say your name correctly. And if I butcher it, this is why I call you Dr. Shah. She's my own personal doctor. So Dr. Shari Ari Najad. Did I say that right? Okay,
Perfection. Yes.
AKA Dr. Shah is a board certified gynecologist and a urogynecologist, which she's going to explain to us in a second. But I also need to give her some props. She is the best doctor. I'm obsessed with her. I met her probably a year ago, and we're going to go into like the whole story. My audience has already heard about my hysterectomy because I really tried to like get as much attention about being like getting the hysterectomy as I could, and really get as much focus on myself, and my ego really needs some more boosting. But before we start, if you're watching this on YouTube, I think Dr. Shah is on a beach right now. She has her like gorgeous palm trees in the background and told me that she couldn't figure out how to get that background off.
Yeah, my 13-year-old put it on and I just do not know how to get rid of this thing, but it's kind of nice.
It's like relaxing. I mean, at least it's not like, have you ever seen that the video, which I still to this day will watch, and when I want to laugh, of that older man getting on a Zoom call and he was like, "I'm not a cat." Oh yeah. Have you ever seen that? Yeah. And he's like, "I'm not a cat, Your Honor." And it's one of the funniest things. So at least you have like a cat background or something really weird in the background. It's a beautiful background. Okay. So let's get into it. I've wanted to do this episode with Dr. Shah for like months, and we've been kind of back and forth. I had my hysterectomy on February 14th because nothing says romance like getting all of your organs taken out. And it was kind of to a point with me where it was a little bit a skosh of an emergency situation because I was having massive issues with my fibroid, and it was causing me to be so anemic that they were very close to not being able to operate on me. So that was a little bit scary, and kind of the first time in my life where I've kind of had a situation where that kind of thing happens and it makes you kind of go, wait a minute, we're all human. And that's a little bit scary. But I decided that I wanted to do an episode specifically. We're going to talk about hormones again, ladies that are going through this pleasant experience called perimenopause and menopause. But I also wanted to focus this on hysterectomies specifically because I don't think there's a lot of information out there or podcasts or people are upfront about what you go through post hysterectomy, pre-hysterectomy. So that's my mouthful. So what do you have? Let me shut up and like you tell me your thoughts on my mouthful that I just said.
Okay. So first thing, I want to explain what a urogynecologist is because it is a new field.
Yes.
So in the past, when you had anything to do with incontinence, really any kind of issues with your organs falling down, which is prolapse, you would be sent to a urologist. A urologist is trained in men, not in women. And for about 100 years, we didn't know that women and men are different anatomies. Isn't that crazy? Only in 2000, I would say the board didn't come out till 2013 did this field become actually official. And so what it is you go through a gynecology residency for 4 years, and then you do a SOAP or subspecialty of another 3 years of just like urological problems in women. And it's a mainly surgical field. It's half and half. It's a lot of surgeries, but it's also a lot of medical management of leakage and incontinence and prolapse, which have a lot of new ways that we can approach it. So that's what urogynecology is. Does that make sense?
Yeah. Thank you for reminding me. And P.S. I had sent a good friend of mine, because I've sent numerous people to you because I love you, but she lives in Pennsylvania. And so I was like, well, you can maybe reach out to her. But she doesn't serve Pennsylvania. But she looked up urogynecologist. And the problem is, which we've done another episode, by the way. So if you're listening and you're a listener right now, you can look back. We probably did another episode 6 months ago where we kind of break down all of this stuff as well. So listen to that episode with Dr. Shah. But she said that the information was confusing in the definition. So they really need to update it, because she was like, wait a second, Meghan, I want to go to somebody because I'm struggling with perimenopausal issues, like menopause, like going into menopause, all of that stuff. And I'm sure you can answer this, but it's probably not shocking that even if you Google it, it's not up to date, right?
The confusing factor is that menopause and perimenopause don't have their own home in education even. We don't learn about it in medical school. We don't learn about it in a gynecology residency. I mean, maybe like, I don't know, half an hour of like hours and hours of education. So there really isn't a specific person to Google or an educational type to Google. Usually it's a gynecologist. You don't have to be a urogynecologist to do menopause management. Anybody can do it, but not everyone can do it right, is the issue. So if you're a gynecologist, you can do a course with the North American Menopause Society, NAMS. And when you do that, then you become sort of the part of the expert field of being a menopause provider. And then you go on their listing. So you can look up physicians who are under NAMS. That would be probably the way to go. There's a lot of physicians out there, gynecologists and general practitioners, who are doing menopause, but they're not doing it right because they're not doing it based on any sort of actual educational algorithm. They are doing it sort of by whatever they feel like.
And so it's a different time in your life. And so maybe a specific specialty, mine was pro HRT and all of that stuff. But some of these doctors don't understand it. So what happens is they go, well, HRT is dangerous. And by the way, HRT stands for hormone replacement therapy. Or you might go to, I hate to say this, but it's true, because the males in this industry, am I wrong to say this? I've talked to several and they're like, but they're like, no, you don't do it. Yeah. So a lot of women are going into this place in their life. And we talked about this in the last episode of like late 30s, you can go into perimenopause. And so I lived for a solid years and years with perimenopausal symptoms, having no idea that I was in it. And that's part of the issue, right?
And it's hard because women go to their gynecologist thinking that they'll get a response of, okay, well, let's talk about it. Let's see where you are and how we're going to proceed. But they basically get, Oh, let me check your labs. If your labs are not exactly what we want, then you're not really in menopause or
Mm.
perimenopause. So just wait until you're 50. That's not the correct answer now. Nowadays, thank God, we recently, Mrs. Biden, our first lady, actually helped a new grant. I think it was something like 100 million for women's research, which is so behind. So a lot
Thank
of
God.
people
Yeah.
are relying on that old research in the year 2000 that was done on the Women's Health Initiative, which showed that you can get there's an extra risk of breast cancer, which then was proven that it's wrong. But that one study has stayed in everyone's head who is not keeping up with the literature. And there isn't that much more literature because there's not money in women's health, unfortunately. So all of this, I think, in our generation is going to change. I believe the next 10 years are going to be much better. Women are much more aware. 50 is the new 30. That's when we like peak in our, careers. And now we're like going through this horrible hell. We're not going to take it anymore. We're not like our mothers that said, well, it's a natural thing. We'll just get through it.
Well, let me just say one thing really quickly. My mom is 80 years old. She'd probably kill me that I'm like announcing her age. And she was on HRT for 30 years and she is doing Pilates 5 days a week.
And that's what it
80.
does. It keeps you young.
Yeah. So, but when she was in her 40s, going through not 40, like 40s, 50s,
Yeah.
and she was like, what do I do? Because her menopause symptoms were so horrifically bad that she finally was like, I just have to go on this. But that was not the norm.
No.
My mom kind of like broke the norm there. And so when I told her, I was having this hysterectomy and like all the things that I'm going through now, she was like, do it. So I have my mom as
that's such a great thing, but that's like an isolated event.
Yes.
Like most people's mothers are telling them, don't do it. You're going to get cancer. Most women's moms are, listening to some of the old time thought processes that are no longer
and
there.
Husbands, by the way. So one of my best friends' husbands did research on it and it was like, don't do it. You're not allowed to do it. And I just said, I was like, please just listen. I mean, the good thing too is like Gwyneth Paltrow's coming forward, spending money on this. Oprah, my queen, is spending money on this. You just mentioned Dr. Joe Biden.
Yes.
So we are focused more on women's studies, but like shocker, like the little blue pill's been around for however many years and we're always pushed to the side, So like you said, it's our time to like not have to have perms and shop at Chico's.
Well, one of the big things is that's newer in this generation is that it starts early. It starts late 30s, sometimes even early 30s.
Can you explain that? Explain that for me. Like, why does it start then? And why do people not understand that?
The research is still really, really not there to explain why it happens. To an extent, the later you start your periods, meaning like age 13 or 14, the later your menopause is going to be. So you start getting symptoms a little bit later. So the pathophysiology in your body is different depending on the amount of fat you have in your body, the amount of stress you have, some of your genetics, but we don't really know that much why it happens. It's just now we're acknowledging it, that it is happening. So we couldn't even talk about this stuff until women were in their 50s. And now we're even putting 30-year-olds on hormone replacement and they're feeling their best. So it's really important to acknowledge it. This new term came out, NFLM, not feeling like myself. That is so funny because it's kind of a catchphrase that has it could be many things, but that is the first thing you start realizing. I'm just not feeling like myself. And that is the start of this whole thing. I mean, everyone's waiting for hot flashes, and it's not about just hot flashes and night sweats. It's about just something being off and you're just not feeling like yourself. Because it's so complicated. It's mood, it's irritability, it's weight gain, it's not sleeping. There's so much brain fog, like all this stuff makes you not feel like yourself because no one can put your finger on it. They're like, I just don't feel good, but I don't know what's wrong. And everyone says, well, you're a mom or you're working, you're just tired. So just take a break, or you're depressed. Let's put you on some antidepressants. But now we're learning that that's not the case. There's so much more to it.
Well, so I have a million questions for you, but what I will say is I'm just going to use myself because I love to talk about myself. Hence, I have this podcast. Joking, not joking. I feel like I really started to have symptoms. I had my last baby later. I mean, a lot of women have babies later now. I mean, there's even women having babies in their 50s, which I'm like, wowzers. How do you even have the energy to, I don't even know how they do that. But I feel like I truly started having perimenopausal symptoms in my early 40s, I'm thinking, because I started to notice like more anger, impatience, weight gain. Oh my God. Like I got to the point in my like a few years ago during COVID, like everyone else, I was drinking too much, that whole thing. But I just started putting on weight and I could not take it off. Mm-hmm. And it was so frustrating. So then as women, we go through the cycle of and me in particular, I'm somebody that had an eating disorder as a teen in my 20s as well. And so when I was putting on weight, I just got to the point where I was like, oh my God, I guess I'm just going to have to wear like muumuus.
Yeah. Oh God.
Like caftans, which I love a good caftan. Everyone knows that. But for the rest of my life, and I'm ready to throw in the towel, which was really an upsetting way to feel. Okay.
When you're 40.
Yeah.
So young, so young.
Yeah. Yeah. So
in the scheme of things.
Yeah. So then I started being like, okay. And then I started having, so I'll get into this as well, the fibroid issue a few years ago, but I started feeling like, is so angry, depressed, weight gain, not sleeping. And my husband was like, what? Like you're like a demon. And
yes.
And so I think a lot of women can understand this, and we're all like, wait a second, but we're not in our 50s yet. So why am I feeling this way? But
why am I not feeling like myself?
Yes. Yes.
That's really what it is. And the interesting part is, again, at that time, if you would have gone to your doctor, they would have said, oh, you're probably depressed. Let's put you on some antidepressants.
Mm-hmm.
Which I am not against antidepressants. I think they're amazing and great and help us. But the problem is that that's only part of the problem. They're not going to really get to the root of the issue, which is your hormonal fluctuations that's like so chaotic that it's making you exhausted. The other thing that's interesting is women start gaining weight at that age and they start to up their cardio. And then
that's what I did. That's what I did. I was doing Soul Cycle and Barry's boot camp.
Mm-hmm.
Yeah, I was losing not 1 pound.
Exactly. Yeah. Because what happens is at this age, the exercise has to change because the more you are doing cardio, the higher your cortisol level goes, which is your stress hormone. And that causes that mid-abdominal fat. So for this age group, we need a whole different way of approaching weight loss, which focuses on, weight training and building muscle instead of cardio, because the muscle is going to do the work of the cardio. So that, there's all this new stuff coming out, both in physical both in the physical training world and in the medical world, in the vitamin world. Like we're just starting to acknowledge all this stuff. So
we're like at the tip of the, I mean, I'm very honest, by the way, for my listeners, and you know this, that I am on trizepatide. So like Ozempic, I'm not on Ozempic, but I'm on the compounded version, and I take it like sporadically. So I don't take it all the time. I don't take it probably the correct way. I don't like feeling nauseous. So I don't do it the correct way. So don't look at me as an example of how to take it. Go talk to your doctor.
Yeah.
That specializes in it. But what the reason I brought that up is because my question to you is, I think a lot of women are using that in conjunction with hormone, with HRT. Can you answer that? Or am I kind of veering into a weird area?
Well, it is. It's a complicated area because
Mhm.
GLP-1s, that's what their category is called, Ozempic, Wegovy,
Mounjaro.
Mounjaro. All of them are in the same category. And, they're newer. We don't understand them that well yet. And we don't understand them in conjunction with hormones that well. We're just starting really hormones. Technically, like, really doing the research with hormones. So we haven't brought the two together that much yet, but it's happening. I mean, these are the questions that we're having. I found that the women who are trying to lose weight and can't lose the weight, can't get over that hump, they really do need the hormones first. And you can then use the GLP-1s as a support to work it. Because when you just use a GLP-1s, it doesn't get you over the hump when your hormones are fighting against this weight loss.
No, you're right, by the way, because you know this about me.
Yes.
So, I mean, I've been on and off them for about a year, and obviously I had all those medical issues and depression, which we'll get into with the hysterectomy. But I was stuck. I was like, why am I taking these shots and I'm not losing any weight? So I might talk about that in a minute and kind of like go into the area of talking about hysterectomies specifically. So a lot of women, right, struggle with fibroids. Can you kind of talk about that? And then we'll talk about my issue.
You know what? Okay. First, I want to get our the terms that we're talking correct so everybody knows. First of all, I want to explain the uterus, like your female organs, because I feel like people don't realize this. So think of the uterus as a jug of water. The jug part of it is your uterus where the baby grows, and that's its only function. Its only function is to hold the baby. The cap of it is your cervix, and that's when you put your hand into your vagina, you hit the cap. So you hit the end of the jug. And that cap, when it opens, is when the baby can come out. Does that make sense so far? And then the two arms of the jug that you hold, that's your tubes and ovaries. And the important part is all three of these are separate organs that then came together and connected. So they each have their own issues, they have their own cancers, and they're separate. When you do a hysterectomy, you can cut either the ovaries out, the cervix out, keep the uterus. There's so many different ways to do it. So people come and say, well, I had a partial hysterectomy. There is no such term, because partial meaning what? Did they keep your cervix? Did they take your ovaries? Like, what does partial mean? So you really need to be clear on that. So there is hysterectomy, which means they remove the whole jug, the cap and the body of it, or supracervical hysterectomy, which means they left you your cervix and then they cut above the cervix and they took the whole uterus. Now our ovaries are still there. And then there's hysterectomy with what we call is bilateral salpingo-oophorectomy. I know it's a mouthful, but that means your tubes and your ovaries. Does that make sense?
What am I? Because what everyone get ready for this. I had everything removed.
Yes.
And except for my ovaries. Right. Are my tubes still there?
No, they should have removed your tubes.
No, they removed my tubes and I just have floating ovaries. Yes. But let me just say, if you're local to the Los Angeles area or the South Bay, I live in Manhattan Beach. Dr. Shah lives in Manhattan Beach. Go see her if you're struggling with any of these things. I just have to reiterate, before I met you, this is embarrassing. And if I have men listening, like, get ready for it. I did not understand my actual vagina before I went in.
Yeah, I know.
And many of my friends, listeners that have gone to see you also did not understand where things were. And that's an issue. But I learned so much. And I also learned, like, why are we so ashamed of these things? Because Dr. Shaw will just like get right in there. And at first I was like, this is really kind of weird. But then by the end, I was like, whatever. And
You mean the mirror?
Yeah. And then you leave and you're like, okay, I guess I'm fine with this. And then you kind of understand that as we age, how the actual vagina works and like the skin, and you can kind of go into this too. But when we talk about the actual jug, if you will, like you just brought up the example of getting the hysterectomy, I would like for you to answer the question of, a lot of women are like, I had a hysterectomy, or they break it down however they understand it, but I left my ovaries in, so I don't need to go on hormones. And I would like for you to talk about that.
Okay. So our ovaries evolutionarily start to shut down around our 40s. So actually, let me go back. Our ovaries hold our eggs. Okay. Our eggs are precious. We release one egg every time we ovulate, just one. If that gives you a sense, a man releases something like 4 million sperm every time they ejaculate. So if one egg, 4 million sperm, it's a miracle we don't get pregnant every day, right? So that's how it is. And that's because that egg is very protected. So the egg is what makes our ovaries release hormones, right? It releases estrogen and progesterone. The egg, since it sits there since we're born, keeps getting mutated. Like there's a mutation every year, which means kind of like a blow to it. Somebody punches it. So something kind of goes wrong with the eggs. That's why as you age, your eggs are not as good as when you were younger. So at around 40s or so, our body is thinking that we've already had our children, whether we have or not. And it starts to no longer want to release these hormones in a very exact way. And then it starts to fluctuate. Sometimes the estrogen comes, sometimes the progesterone. It just kind of fluctuates. And that's why your periods get all kind of wacky and your emotions get wacky until around whenever it's going to stop, which is it's your 50s. So that ovary will shut down around 50 no matter what, or 49 or 52, plus or minus. Whether you have a hysterectomy or not, that ovary is shutting down. After 50, whether you have a hysterectomy or not, your ovaries shut down. So no matter what, it's not functioning anymore. So even though you kept your ovaries, you're not getting any benefits of the hormones because your body thinks it's all shut down, it's done. And
so it's like the kitchen is closed. I had an ultrasound, that's at my other doctor, and the guy doing the ultrasound, he was telling the assistant, like writing notes. He said that my ovaries were what's the word? Corroded. Does that sound right?
I don't know. I've never used that term on an ovary.
But I literally was like, what? I was so offended.
Atrophic.
Atrophic. Okay. Right. So that means the kitchen's closed.
Pretty much it means shriveled up, which is awful.
Well, I have no parts anymore, so it doesn't matter. They're just like floating in there right now, so it's fine. I'm not offended.
So the reason that they take the tubes is because new literature in the past 5 years has shown that most ovarian cancer is caused by the tubes, which is the attachment from the ovary to this jug. That's how your egg flows in. Mm-hmm. So now, even if you're keeping your ovaries, we cut out the tubes. So technically, you had a total hysterectomy, and that's it, which means they took your cervix and your jug and the cap, and the handles of the jug, but not the ends of the jug, because that's your ovaries.
Okay, what about if you're somebody that's okay? I'm going backwards because I'm kind of skipping around because this
No.
is how my ADHD brain works. So what if you're somebody that like was in my shoes, for example, that had to, like, I really tried my best. I did everything. I had the ablation.
Yep.
I had the partial removal of the fibroids several years ago. And with my case, it's stuck
Yep.
to my uterine wall. So it grew back is what happened with me. And then, and I think a lot of women can relate to this. What happened was the fibroid was so big in my case that when I would get a period, I would be terrified to leave my house.
Yeah.
Because I would bleed through my clothes. And then I started becoming anemic. And then I went to my doctor before I met you, who I love, my OB-GYN. And she was like, I can't get it out again. Like basically it's cut to your wall. So in my case, there's different things you can choose, different ways to get the hysterectomy. I did mine. What did I do mine? Robotically. Thank you. So can you explain the fibroid issue as one of the causes of why people need hysterectomies and why in general people do?
So there are 3 reasons that you absolutely need a hysterectomy. Well, one is cancer, uterine, cervical, ovarian. That's one reason. The second one is if you're bleeding and it cannot be controlled in any other way. And the third is if your fibroids have gotten so big that there is no other way to take away the pressure and the pain and the discomfort of it. So those are really the 3 reasons. Back in the day, they used to do hysterectomies on women if they coughed. Oh, wait, the 4th reason is possibly a prolapse. But that now we're bringing in new studies where we're keeping the uterus in and doing the prolapse surgery. So prolapse means everything coming down. Okay, so let's talk about fibroids specifically. Fibroids are a growth of the muscle of the uterus. So the body of the jug is a muscle, just like your muscle that your biceps or anything. That's what it is. It's a muscle. And those muscles can grow this thing that we now for years and years, we really still don't understand why it starts, but it grows fibroids. So it starts to grow almost like a ball-like structure into the muscle. Now, as it grows, almost 80% of women have fibroids, but not all of them even know about it or feel it. It's only when the fibroids become something, cause a problem, do you need to do something about it. So there's lots of women that'll go to their doctor and they'll do an ultrasound for some reason, say, oh, I have fibroids. It doesn't matter. You don't need a hysterectomy unless they're doing something to you, or if they're growing super fast that we're worried about cancer. Okay, so this growth of the muscle can start within the jugs, like the glass of the jug. It can start growing within the jug. So from the muscle, it goes into the jug where it's inside the inside our jug. And those are the ones that cause a lot of bleeding because then that's where the jug goes to the opening, to the cap, right? So the blood can come out that way. So that's called, so there's a submucosal, that means within the cavity of the jug. Those are the worst because they bleed a lot. Then it can grow outward. So outside of the jug, I have had fibroids grow so big that they came and they even attached to almost below the lung tissue. Like
oh my God.
Fibroids are like a parasite almost. When they're there for a long time, they start wanting blood. And so they start creating vessels that attach to other organs around, and they want to grow, and they grow with blood. So they're very bloody organs. So when you become menopause, so estrogen feeds fibroids. It's not the only thing, but it's one of those things that helps it grow. Why? Because estrogen is a growth factor. Estrogen is, and that's why estrogen makes our skin glow and all of those things. It's a growth factor. So these fibroids, when you're young, they grow because they're getting estrogen. So when you get to menopause, your fibroids should never grow anymore. They should just.
Why was mine?
Because you were still perimenopausal.
Oh, okay.
You're still not totally menopause. Your ovaries are still functioning. They're just not functioning well. So as long as you are not complete menopause, which is 12 months of no bleeding, your fibroids can still grow.
But why was mine growing so rapidly? Like having it, like there's women I'm sure that can relate. And correct me if I'm wrong, mine was prolapsed. So that's why I had to have my cervix taken out.
Yeah. So I met you at a point where I hadn't seen you before. So I don't know when your fibroid got to this size, meaning did it really grow rapidly, which means like 1 or 2 sizes within 6 months? Or really was it a gradual growth from when you were 40? When you had your last child, was it kind of growing little, and then
it was removed and then it grew back within 2 years to the size where it was. So I was just curious as to if that's normal or like are women that are listening.
It's not as common.
Okay.
And yes, you can remove a fibroid, but that doesn't mean you remove all the cells of the fibroid. So other fibroids grow. A lot of times when people go in and remove whatever fibroid there is, and if you still want to get pregnant, they're very careful not to take out too many things because you don't want that muscle to be all messed up to be able to hold the baby. So you take only the ones that you need to, with the risk of the ones that are left are going to grow again. So, okay. So you can go in and get a myomectomy, which means you go in and you carve out that fibroid and you take it out. But it only depends on where the fibroid is grown. If the fibroid is grown so much that it's gone through your whole uterine wall, if you remove it, you're going to mess your uterus up. So you can't really be able to carry a child that way, or it's dangerous to be able to get pregnant again if you were in that range of things. Now, for you specifically, you had 2 C-sections, right? I
sure did.
Okay. So every time you have a C-section or any kind of surgery, you get adhesions, meaning things sticking together. And so once you start having things stick to your uterus and you have this fibroid growing, then the fibroid has the ability to get closer to other things and start getting bigger and start parasiting and grabbing onto your side wall. That's what it was doing. It was catching the side of your abdomen from inside. It was really big. And yours was not stopping. So yours was one of those, like a lot of people do. If you're bleeding a lot, you burn the inside of the uterus that you already had.
The ablation, by the way, if you're a listener, explain that because that's something you can do too.
So what it is you take the jug, you open the cap, and you stick like a big candle inside and you burn the inside wall so that it doesn't bleed anymore. And that works really well for a lot of women who just have this weird bleeding that has nothing to do with fibroids. Fibroids themselves don't really respond to that unless they're super small fibroids.
Interesting. So that's why it didn't take for me.
Yeah.
Okay.
Your fibroid was really parasitic and just full of blood vessels. And that's why it was such a dangerous fibroid. And it kept bleeding. And you really didn't, we really tried not to take you to surgery. The first thing you said is, I don't want to be opened up again. I don't want to be opened up, which you don't have to. So this is the other thing is, please, before you do a surgery, get a second or third opinion. We are all trained differently. And you really want to get to where you feel really comfortable with what you're about to do. If you have hesitation, trust your instincts. Like there's a reason. Hysterectomy comes in. There's 4 ways to do hysterectomy. Should I get into that, or do you want to stick with the fibroids?
The whole episode could be about me and my fibroids. By the way, while you're talking, I've been binge watching Stranger Things. So for my listeners, I mean, I'm sitting here like, oh my God, my body was like Stranger Things.
Yes.
I've never seen it before. And now I'm like on like the fourth season and I feel like I'm like Stranger Things. But I kid, but just to like put go back on the fibroids really quickly, because after the episode that you did like 6 months ago, listeners reached out to me and said, like I'm having these things. I have listeners everywhere, but saying, I have fibroids too. And I went to the hospital and because the bleeding was so bad and this is an awful way to live.
Yeah.
And
you shouldn't live that way.
You should. So what I want to say about my particular situation, and like Dr. Shah just said, get a second opinion, because I did. So I loved my doctor. I love my doctor, my other doctor. And I chose to not do the surgery. This has been going on for years with me.
Yeah.
And I chose to have a second opinion because I wanted to if I had to do the surgery, I wanted to get it done a specific way.
Exactly.
And I also was getting to the point with my hormone issues. So that's how I ended up meeting Dr. Shah. But I want to say to the listeners that might be listening right now, and they're sitting here going, I'm just going to live this way. Or it's, like I'm almost at menopause. I'm in my late 40s, like I was in my condition. And let me just tell you, I'm being honest. My life is completely changed from doing the surgery. And most women that you talk to, because I talked to many women before I chose to go this route, told me the same thing. They said, your life is not fun when you're dealing with this. So a lot of women that have fibroids have pain. I did not in my case. A lot of women, you'll go out to dinner and you're afraid to get up from the booth. I would go to carpool to pick up my daughters, and I was afraid that I had to have something tied around my waist, or you're wearing like giant pad underwear because you're constantly terrified.
Yeah.
So let me just say, and maybe you can piggyback on this once I stop my big giant mouth from talking. It is not a way to live with these fibroids if they're like that bad.
Right.
And there is a light at the end of the tunnel. And let me just tell you, it is a life-changing light at the end of the tunnel. So I am 4 months out, February, March. Yeah, I'm here. I can run a little bit. Not really. I'm joking. I can't run anymore because of my back. But I'm doing things I wasn't able to do before. I'm happy again, like living
You're
my
not depleted. I mean, all your blood was going.
I was also exhausted. So you're probably anemic. So go to the doctor and get your blood taken. I almost couldn't. I had to have multiple infusions at the hospital because I could not. I was winded going up a flight of stairs. So like the trickle down effect of this, it's also dangerous, right? To get that severely anemic. So I'll shut up, but I just wanted to say that before we moved on to the different kinds. So you go.
Most doctors should be trying their best to try to not do surgery on you. That is always the goal, is to try different things and stop the bleeding. There is some radiological ways to start making the fibroids smaller, where they zap it basically with under radiology. It doesn't work that well. It only works for patients who are having pressure. It's not going to work for someone who's bleeding. Excuse me. And there's all the stuff that we're trying to do, but there's a point where when you're bleeding this much, it's not going to just go away on its own. even menopause for some of these women who are going through this point doesn't end it. You're still bleeding because your fibroid has now found arms and is getting blood supply from other parts of your body. So just because your ovary stopped, it doesn't mean it stops because it's gotten so strong. It's a parasite.
It's like Stranger Things.
Yeah,
it is Stranger Things inside your body. You're
Exactly.
welcome. Tell your patients that. I just taught you something.
Oh my God, I love it. So, I mean, with Meghan, it was just really at the end. But, I think we tried. There are new medications, tranexamic acid. She tried everything, really. And you want to get to that point where you've tried everything. You're like, okay, I got to get surgery. So now when it comes to surgery, when you're finally like, all right, there are many different ways to do the surgery. She was terrified of another cut, which is completely understandable because if you go back into a body that has had multiple adhesions, when you cut again, you have the risk of cutting your bladder, your intestines. It's a very difficult surgery. You don't want to go to someone who does the surgery once a month or even once every few months. You want someone who's doing the surgery weekly. That you have to go to the surgical experts. You may love your gynecologist, but may not be the person that needs to do the surgery for you. And that is the big part that I think people are scared to do. Like they feel bad. I feel bad. My gynecologist is going to be sad. No, even if they are, this is your body and your health. This is not a joke. Like it's a major surgery. You want to go into the best hands to do it. Someone who does it a lot because it's very complicated surgery. So now how do you do surgery? So there's 4 different ways. One is you go into the vagina and you take the whole uterus out. That's called a vaginal surgery. No cuts on the belly or anywhere like that. You just go through the vagina and pull it out. That is the safest type of surgery. However, hardly any gynecologists are being trained on it anymore. It's really sad, but gynecology has now divided up into the general gynecologist who does your pap smear, does all that stuff, and then all these subspecialists. The one who does your reproductive, gets you pregnant, the MFM, which is your high-risk pregnancy, us, which are your surgery people who did another 3-year. So there's the oncologist, and then there's the urologist. So you have those. So they do most of the surgeries. You don't want to go to someone who's only been doing pap smears to do that major surgery. Even though they know how to do it, they learned it, but they're not in there every week doing it. It's just like any other skill. When you're there, you've seen complications, you know how to manage it. So you really want someone who's been doing it a lot. Okay, so vaginal is the easiest, and it's not the easiest. It's very difficult surgery, but it's the least risky. The next.
Wait, can I ask a question? Because
Sure.
I want to ask about side effects for each way. Okay. If you do it vaginally, which is more rare, you're saying these days, what are some of the downsides of doing it vaginally? I'm going to ask you that question for every way.
Okay. So we know the pluses are there's no cuts. It's easier to heal. What are the downsides of vaginal? One is you cannot do it with a huge fibroids. If you have a huge fibroid, there's no way we can pull it out of a small little vagina. So it's limited to patients who have other things. Like if you had bleeding without the fibroids, you're a good candidate. What is the negative? The negative possibly is that, well, one, you have to find a surgeon who knows what they're doing, and that's getting more and more rare. So urogynecology, the field that I'm in, we specialize in vaginal surgery. But that's like, you have to find someone. 2, when you take the whole uterus out, that means you don't have the option of leaving the cervix, which is the jug's top. That top is what naturally is at the end of your vagina when you're having sex. When you remove that, it becomes just a suture line. So
I'm sorry for my face, but
I know.
go on.
So that suture line can be very tender. Some people think that that sex is a little different with it. The French did a big study because they were it was very important to see the difference in the sexual function of women who had the full hysterectomy, which means removing the cervix or not removing the cervix. And they found that it's better to leave the cervix. There's lots of studies out there, different opinions still on that. But that's really the main, it is a blind surgery. So that's why the surgeon has to be really good, because you can barely see in there. It's all by feel. And so you can have the risk of cutting something and not being able to control it. But really, that happens very rarely for someone who knows what they're doing. Okay. So those are the negatives.
Okay, so go to the next one. But can I just say, in my case, and we'll talk about the way that I did it. I didn't have a choice. I had to have my cervix removed.
Yes.
So, and I'm going to just tell my listeners, when I told this is actually kind of funny. So, this story, but, the doctor, so when I had the surgery, the way that I did it, which we'll talk about now, they said no sex for a month. And so I went to see you and I was like, I'm doing great, like no sex for a month. And then you said, you might want to extend that because you had your cervix taken out, which means that it's basically just sutured together so your organs can fall out.
Exactly.
So when I told my husband the story, because, like men are men and we're married, he was basically, his face was like, okay. I think we're good. Like, yeah. I can wait however long you would like to wait. So maybe ladies, don't tell your husbands like that detail like I did. Not like the sexiest thing to tell your husband.
It's interesting because people don't listen to you a lot, doctors. And I've had patients who had sex early.
Oh, no.
It's horrible. So then the suture separates. There's nothing holding that. So your intestines fall through your vagina and it's a major emergency, like you can die.
Oh my God.
And you're just like, all you had to do was just wait, just listen to me. And then they have to sometimes get cut now and it's major surgery. So listen to your doctor. Take the time.
So don't do that, please. Yeah. Okay. So then talk about the other two. There's three options, right? So then talk about the other.
So then the second way is an open hysterectomy. So what does that mean? That means that they cut you like a C-section. Sometimes if it's so big, they have to cut you the other way, which is coming straight up your belly button. So they open your entire body up, get in, and they're able to see and feel everything. Now, so for people who've had really bad adhesions, meaning things stuck together, a lot of doctors need to do that to be able to visualize how to get this huge thing out. And then you have to take it out of the abdomen, like the full thing comes out, not through the vagina. So that surgery is the hardest to recover from. It's, your entire intestine. It's the riskiest because it's got everything around that you're touching, you're putting together, your abdomen, your muscles. It's very hard to get over that one. That one really takes a long time. And we really nowadays try not to do open hysterectomies. People who don't do many hysterectomies and have a complicated patient like Meghan will then advise her to do an open because it's so complicated that they can't do it vaginally and they don't know how to do it the other way that I'm about to tell you. So that's an open hysterectomy. And that's what we used to do for all cancers, which now we're not even doing that anymore. Why? Because you want to bring the uterus out as a whole when you have a cancer to send it to pathology. So now we're going to the third way of doing hysterectomy, which can be divided into that third way into two ways. One is so laparoscopic or robotic is basically the same thing. All it means is you make tiny little holes in your belly. You don't make a big open cut. And those tiny little holes, we have instruments that go in and they do our surgery. Our hands, it's like a video game. Our hands are on the top and the instruments are doing the surgery down there and we move it. Okay. Why is that a good way to do it? Is because every time your hands are inside the abdomen, it causes adhesions. And by not putting our hands in, we're decreasing the risk of you having more and more adhesions. Scar tissue, that's what I'm talking about. That's what adhesions are.
Mm-hmm.
And the other thing is I don't cut through your belly and your muscles, and everything is not exposed to the world. So risk of infection is lower, recovery is better. So it's the best way after having a vaginal. That would be the best way. But it is very hard and not everyone can do it. So you have to go to the experts. People say they know how to do it, but unless they're doing it weekly, you should not be doing it. Honestly, you have to be doing it weekly. If you're one of those that does it once a month, that's not even good enough.
Okay. And also to piggyback on that, I love saying piggyback. I think I sound so smart. That you would not want to do that. I mean, I was terrified doing the robotic surgery. I didn't go to Dr. Shah. She referred me out to somebody else that's all he does. So all he does is these surgeries. And my experience was you end up in the end with I would show you my belly, everyone, for YouTube, but you don't want to see it. Also, I have my hot stuff estrogen patch on. What? So we'll go into that. But you just end up with three scars. You have 3 or 4. I think one's on my side, one's near my belly button, one's on one side, and they're really, really small. I'm now going into the phase of the dress bathing suit. I'm not going to be wearing bikinis anymore. So I think I'm good. I'm a one-piece gal.
And it'll heal. You'll miss the incisions will start not looking as much.
I mean, they're just little, it looks like little scabs on my stomach. It's not a huge deal. But I just wanted to say that's what I had done. Okay. And then mine was complicated. The doctor who did the surgery said it was very complicated. So I had to have my cervix taken out.
Right.
And
so
yeah,
the reason you had to have your cervix taken out more than anyone is because your fibroid had grown into your cervix.
Mm-hmm.
So there was no way of removing that whole thing without your cervix coming out with it.
Mm-hmm.
So they make these little incisions. We get the whole uterus off of everything. And then actually he cut it into half or so and then was trying to get it out of the vagina. That's why you had a lot of vaginal pain, because he was trying to pull this big old thing out. He was having a hard time. So then he cut it in half. So it was a little bit of a struggle. Think of think of when you're trying to put on really tight pants and it's your belly's kind of hanging and you're pulling this pants. It was kind of like that. It just is hard to get it out. Does that make sense?
And yes. And it was not, I'm going to be honest for my listeners. If you're in this position and you have these options, thank God for pain meds. And I really weaned myself off quickly because I'm paranoid about that stuff, but take them as long as you are directed to. I'm an idiot and I wean myself off of things too quickly. And then you end up with issues.
Yeah.
I'm not going to lie. I didn't understand why I was having so much pain because I had C-sections. So I basically gave birth and didn't understand that that's what was happening.
You had a 12-pound baby.
Yes. And it was really painful. So, and the other thing that I'll add that you can maybe speak to is, I mean, it's uncomfortable. It was painful the way that I did it, but I would assume most women that do this don't have to have their cervix taken out like I did and don't have that giant 12-pound baby. Yes, okay. Yes. The worst,
you had double.
Yeah. The worst part for me, hands down, if you're listening, was the gas pains.
Yes. So when you do it robotically or laparoscopically, we have to put in a lot of gas in your belly and blow the belly up so that we can see inside. And as well, the abdomen goes away from all the organs so we can cut into it. So that gas then needs to be released afterwards. And that is very uncomfortable. So I can just tell you that robotic and laparoscopic are excellent surgeries. They do have their own set of pain issues. and they have their own set of risks. Again, if you're with someone who doesn't know what they're doing, the risks of a complication are huge because they could be operating in there because we use heat and they can burn your intestine and not have an idea that they did it. They can cut your ureters that go to your kidneys. So the risks of something going wrong with that is high. The benefit is you don't get big scars. The healing is technically better for your body. You don't have scar tissue as much, and you don't have big incision for infection purposes. So, so basically you actually had a robotic assisted vaginal hysterectomy because they had to take it out of your vagina. So you had kind of the worst of both, or whatever, the most pain of both. You have the gas pain of the robotic and you have the vaginal pain of a big, huge thing coming out. So what happens afterwards? So now I sent Meghan to an amazing, amazing surgeon who is really knows what they're doing for something this complicated. And this is another thing. I don't know. I guess as a surgeon, I know what my limitations are. And if there's something that I don't think I'm going to be able to handle, I should really have the patient's best interest and send them to someone who I think can do a better job at this. If she needed a vaginal hysterectomy, I would have been better at it.
Yeah, I wish we would have said that because I didn't say that that was part of the reason. But also, hello, that's why I love you, because you were like, listen, that's called being a good doctor, by the way. I'm just going to give your ego a little boost there.
Well, I think it's one of the Hippocratic oaths that we get is first harm, but people forget with their ego that it's okay to say to a patient, this is not something I'm very good at, or your case is too complicated for me. You should go to this person. And that saves lives. There'll be plenty of things for me to do with Meghan. I don't have to do her hysterectomy and put her at risk. So he did a wonderful, wonderful job, but he doesn't have the best bedside manner or post-operative follow-up. And that's why I told her, don't expect that. Just come back to me and I'll take care of you post-operatively. So it's really important. A lot of surgeons who do this so much, they forget that that's the patient's only time they're doing that. You may be doing it every week, but she's going to suffer. And they say, 2 weeks and you should be back at work. And that is not true. It's extremely rare. I would say 1 out of 1,000 can go back in 2 weeks. It is hard on your body. It is a surgery. Even if everything went perfect, going through that anesthesia is like running a marathon. So you're exhausted, you're tired, and that fatigue causes you to emotionally just drop down. You get teary-eyed, you get emotional. People think they're losing their mind. I always warn them, you will cry and you will be so depressed for a short time. And it has nothing to do with your ovaries. It has to do with the fact that your fatigue of your body. Now, she kept her ovaries, right? She was at an age where those ovaries were shutting down. So sometimes the stress of surgery will, make that happen faster. And so her ovary basically shut down. But if she was 30 and doing this and keeping her ovaries would still function.
Okay.
But because
that's why they
already around menopause, it just kind of pushed it forward, right? Basically, leaving or taking your ovaries depends on what age you are, whether they work or not afterwards. And that is what determines whether you need hormones or not hormones.
Okay, but let me ask a question on this. And by the way, listeners, this is going to go a little long today because we have work to do. And don't worry, I won't keep you here for 2 hours, but this is important stuff. And I think there's not enough information talking about hysterectomies and menopause, perimenopause. Yeah, I could talk about it all day. But what I want to know is when you get through the hysterectomy, you're somebody that already maybe struggles with depression, or we're women, we're at a certain age. You warned me, you were like, listen, you're probably going to be depressed afterwards. And for me, I already struggle with that. That was not a good situation. But what do you say like about the fact that I had very high estrogen levels and then my body was just like immediately, I don't know if you remember, you tested my estrogen levels, they were off the charts. And then my body was just like completely stripped of all the estrogen. And then my estrogen went from being really high one day to completely gone and low. So is that part of it? I would love to know.
So, yes, I mean, for your particular case, you had these fibroids that were producing estrogen and so your estrogen was high, and then they didn't take your ovaries, but just the stress of surgery probably shut them down completely, and then they dropped. So it was traumatic for your body. Other people who didn't have as high estrogen and they also either take their ovaries or the ovary shuts down will have a drop as well. They can get depressed too. So both of you need something postoperatively. I've had patients that I put on an antidepressant for a month postoperatively, and then they came off of it. They just needed to get over that period of time. So don't be shy about telling your doctor that you're feeling down, you're not feeling good. So, but Meghan specifically also needed hormones. So she needed a combination of both in order to get through this period of time. If she chose, she could do that. We usually like to start you on hormone therapy at least 6 weeks post-surgery. And those 6 weeks can be tough. So
They are. I'm just going to tell you that.
Yeah.
Yes. For my listeners that are out there considering doing this, again, I'm going to reiterate all the things she said, go to the right person, all the things we've talked about. It's worth it in the end, but it was not a fun experience feeling that way. And you kind of feel like it's almost like if you're somebody that struggled with depression, like post having a baby, it's that feeling. And you also are mourning. Like, I know I know that my kitchen was closed. I know I wasn't having any more babies.
Right.
But it is like it's a weird thing. It's a very special organ for a woman, organs, because it's the end. It's the end. So you're like, in your head, you're kind of like, I mean, I was like, I felt almost like stripped of being a woman. And I felt like all these weird feelings about it of like depression about like, oh, I'm old. I'm old now. Like, I'm not going to be attractive anymore. Like you go through these like weird things in your head. And then at the end of the road, like all these months later, I'm going to be honest with my listeners and sorry for the TMI. I'm doing like great. And your sex life can come back. Mine is, thank God, good. And sorry, Ron. Sorry, Mom, if you're listening. But I just wanted like people to know there's a light at the end of this tunnel.
You're not going to feel this way.
No. You will not. Go ahead.
You really need to address it though. For some people, it's 6 weeks. For some people, it's 2 months. I honestly can tell you that I tell my patients, you give yourself grace. A lot of people, it takes them 3 to 4 months to start feeling like themselves again. There is no this time limit that surgeons say, well, in 2 weeks, you'll be fine and you can go back to work. And by 8 weeks, 8 weeks is just not enough time. I just don't think it is. Now, does that mean that you physically can't do stuff? No, you can. You can type and cook and do a lot of those things, but inside you're still healing and emotionally you're having ups and downs because even if you're young, your hormones are going up and down because those ovaries had stress. So you got to really give yourself grace. You got to realize that it takes months. Okay. This is a major organ we just removed. And some surgeons don't even have a 2-week follow-up. I don't know. They see their patients like 2 months later because they don't even want to deal with all that stuff that happens in between. But I think that's the most important time to be there for your patient. You really got to do the 2-week follow-up. We do it at 2 weeks because your body needs a little bit of post-operative just rest before we check you and make sure that everything's healing well, the incisions are right. It's not a fun exam because you're like, I don't want anyone to touch me at this point, but it's important to be looked at and make sure you don't have any weird discharges, all kinds of stuff, and to emotionally address you. And then usually my next follow-up should be around 2 to 3 months, because at that time you should be really healing, have gotten to a point of good healing. And for some people, it takes a year. I'm telling you that don't feel like there's something wrong with you if it takes you a long time to be able to get out of bed, to be able to move the way you did. It just takes time.
Or work out. Just for me, I was so lazy. I also still was anemic. It took me a while for my blood to like balance out all of that stuff. My hormones are just starting to come back, and we'll talk about that right now in closing, because I don't want you to be like, I'm stuck with Meghan for 5 hours. But I had no energy to work out, and I'm somebody that tries to stay pretty physical. So don't push yourself if you're listening and you're about to go through the surgery or you just did. I just probably started working out again. And like I said, we're almost in August, and I did this in February. Yeah. So it takes a while.
Listen to your body. I think women forget that their body tells them. If your body's tired, you don't get a medal for getting up and working it out. This is not that type of time. If your body's tired, rest. Rest when you can, walk when you can. It is important to be somewhat active, but don't push yourself. You got to eat protein. Protein is a big, big thing. If you don't eat protein, you will not heal. I've had vegetarian patients that I've had trouble with their healing. So just really remember protein's important, however way you want to get it. I do these surgeries in Africa, and the women there have no protein, and it's impossible to heal them. So we send them protein powder 6 months before we're going to go and do the surgeries. And now it's so much more successful. So protein is super important at this point for the healing. So
I don't eat meat. I don't know if you remember, I told you that. So if you still eat eggs, I am a pescatarian. I eat a lot of fish and eggs.
Yeah.
And egg whites, because we're working on getting my cholesterol down. So let's go now into post-op HRT briefly, because we talked about it on the last episode. I would like to tell you all that if you would like to see my scars in my stomach, I have a wonderful little patch on my belly. I rotate it because I've been on estrogen now probably like a few months.
Yeah. Maybe 3. I haven't quite made 3 months yet, I think.
I don't know, but I'm night and day from how I was feeling, but just by starting the estrogen patch. And then I just incorporated in the past day, 2 days ago, the testosterone.
Woohoo.
So I don't know if that means I'm going to grow a beard or what's about to happen to me. I'm a little confused by like the dial that you turn. So can you talk about, and then I think I'm going to start progesterone, but I don't know what's going on with that. So can you talk to my listeners kind of about like those 3 things and how everybody is different and might need different things?
Yeah. Okay. So, first thing, these molecules, estrogen, progesterone, and testosterone, they all come from cholesterol. Cholesterol molecule changes, becomes estrogen, and becomes progesterone. Estrogen changes and becomes testosterone and goes back and forth and toggles back and forth. In women, the estrogen stays high and a little bit of it goes to testosterone. In men, the testosterone is the big amount and a little bit of it stays as estrogen. So that's the differentiation of men and women. But we have all 3. All of us have all 3. Estrogen for us as women comes in, fills our uterus up with thick tissue, so that if a baby is born, it has a nice soft spot for it to grow. Progesterone's job is to come in and clean that out if you don't get pregnant, and that's your period. If you do get pregnant, then that estrogen continues to go up high and it continues to grow and have a soft spot for the baby. So for women who've had a hysterectomy, they only really need estrogen. They don't need the progesterone because the progesterone's job is to protect your uterus by cleaning you out. So estrogen is the main factor that makes you feel better, is the growth hormone, is all of our feminine needs. But some women need some progesterone. So for Meghan, she just really needed estrogen. But progesterone does help with sleep. And so sometimes we'll just add progesterone to help with that sleeping time if someone is still suffering with not being able to sleep. Otherwise, most likely you don't need progesterone.
Mm-hmm.
Now, testosterone is our hormone that helps with weight loss because it helps, you know how men have better metabolisms than we do because they have a lot of testosterone.
Jerks. Yeah,
Testosterone,
go on.
I know. Testosterone helps with that, helps with your sex drive, helps with sexual intensity, being able to have an orgasm, getting to the orgasm faster, all of that. So a lot of women, once they have their estrogen at a good place, this is a big thing I want everyone to know. People say, like they go to a doctor, they get a hormone patch or whatever, and then they never see the doctor again. And they're like, well, you know, hormone therapy doesn't work for me. Because it's not a one-time thing. You've got to get to the point. You've got to be seeing your doctor regularly to get it to the point where it works well. It is not a one dose for all. Nobody knows how much to start with. So my theory is I start low and then I go up to where I find that all your symptoms are taken care of. When your estrogen in your body is at a good place, it naturally turns into testosterone. So the thing in perimenopause, or menopause, the last thing that we get to is the sex drive. That happens last. First, we get rid of hot flashes, then irritability, then sleeping, then it's brain fog, and then last is sex. It's because you naturally can turn into testosterone. And then if you don't quite get that testosterone enough is when I add testosterone. Why? Because testosterone has a lot of risks with it too. You don't want to go too high. You can get clitoral enlargement, which sometimes is not reversible. You get weird hair growths. It has cardiac issues. So you don't want to just suddenly have this huge amount of testosterone. You want your body to gently get it. Because there are some people who have come to me and their doctor has put them only on testosterone because they went in complaining of sexual dysfunction and they were still perimenopausal. That is not the way to go, because what happens is, yes, you get all like sexually ready to have sex because they put you on this huge amount of testosterone. You feel good for a while, but it doesn't take care of all your other symptoms.
Mm-hmm.
And then you have to wean down on that testosterone and then wean up. It's just way more complicated for your body stability. Body likes stability, slow gain. So that's the difference between the three.
But what? Okay, so there's different ways to be on these. So can you talk about that? So I'll use myself as an example. I'm on the patch, and I started on one dose and then way up to my dose a little bit. And then I just but I also have a question because why did we add testosterone for me? I don't remember.
For you specifically, I wanted to, you were having a really hard time with that jump of weight loss.
Oh, okay. So am I on a really low dose?
Very low dose. You're on the lowest dose possible.
Okay. So I'm not going to grow a beard.
No,
okay.
Not on my watch.
That's what I was a little concerned about. And so, okay. So can you talk about the pellet? We talked about the pellet, and the pellet is not good because it's just giving off a bunch of hormones.
Okay, so I'm going to tell you about the different ways you can get it. So you can get it as a pill that goes in your mouth, right? Mm-hmm. So estrogen, progesterone is always a pill, just so you know. The estrogen part can be a pill. It can be a patch you put on your body. It can be creams that you put on your body, or it can be that's it, really. Pellets, sorry. So what are the differences? So the pill is goes through your liver system. That's how just like any other pill, like Tylenol, like Advil. So and that's exactly where your clotting factors are, is in your liver. So patients, for example, who have really bad cholesterol, or they have history of a clot or anything like that, we want to be more careful with. We don't put them on the pill. We put them on the patch, because the patch does not go through your liver, doesn't affect your clotting system, which can cause a lump going to your brain, your heart, etc. So the patch, I would say, is the safest. The cream does the same thing. The problem I have with the cream is, and this is all kind of personal, I tell patients, try the different ones and see what works for you. I don't like the cream because you put it on your hand and if you touch, you got to keep it dry for an hour. You can't touch anybody. Like if you have kids and you hug them, you can transfer it. So it's just more complicated to me. As a mom, a working mom, I don't have time for that. And taking a pill every day is it can be okay, but I feel like the patch is the easiest. You just put it on your belly twice a week, and that's it. It's easiest. It has the least risk, but some people can't tolerate it. Like their skin gets irritated or it falls off. Some people just have too oily of a skin; it falls off. So you have to see what works for you.
I love the patch. I'll just say that for my listeners.
I love the patch too.
I've been really happy with it. I did have skin irritation in the beginning, but that was very brief. Go ahead.
Yeah, mine. I had a little skin irritation. I put a little over-the-counter hydrocortisone. Went to the other side. It went away.
Okay.
Okay. So the pellets. The pellets is very controversial area, because what pellets are basically like a gel that you get estrogen, progesterone, testosterone, or whatever you want to put in there, and then you put it under your skin. It cannot be removed. It cannot be removed. Every 3 months, you need to change or add to it, because the gel dissolves and goes away. But for those 3 months, you're stuck with what you have. If it's too high or too low, I can't do anything about it. Well, too low, I can add. But if it's too high, you can't remove it. So you got to live with whatever it is. That makes me uncomfortable. I like things that I can reverse, I can take away. If the patch isn't working for you, you take it off and you're done. It's not like there's residual anything left. And right now, the North American Menopause Society, which is sort of what we follow, and ACOG, which is American College of Obstetrics and Gynecology. So if you want information, you go to ACOG or you go to NAMS, NAMS or ACOG. Those are the legit places. Don't go to WebMD. Don't go to some of these random things, because you're not going to get correct information. So both ACOG and NAMS do not recommend pellets at this time. So they're not approved. Now, some doctors are doing them. And the other thing is they cost money. Like the pellets, I think it's like $400 to $500 every time you put it in. Some people don't mind that. Some people love it because they're like, I don't have to worry about anything. But on the general whole, they're not recommended right now. And you have to understand that you're stuck with what you get then. So there's nothing like can be done during that.
Is the pellet like everything in one? So it has like testosterone and okay.
You can make it whatever you want.
Okay.
Oh, so I want to talk about two quick things before we go. One is people come to me and say, I'm on bioidentical. Okay. Everyone is bioidentical at this point. The studies that were done in the year 2000 with all those problems, those were medroxyprogesterone and estrogen that was made out of based on horse urine. And those had a lot of risks with them. Bioidentical just means that they are formed from a plant that is very similar molecule to our body's estrogen. And at this point, everything's bioidentical. All the patches, all the pills, no one's really doing the other one. So don't think that it's a special thing when a doctor says you're doing bioidentical. The FDA approved patch is bioidentical, so is a compounded cream. You don't have to get compounded creams to have bioidentical. What is compounded? Compounded is you go to a pharmacy as a doctor and you say, put a little of this, put a little of that, put a little of this, and make that pill for my, or that cream for my patient. I'm a little weary of bioidenticals, and here's why. I mean, compounded, because you can't control if that, whatever we give you is exactly what we give you. The only time I do compounding is when it's things that are not available. Like estrogen and progesterone are available, FDA approved, insurance covered, $20. You don't need to go compounded for you, only if it's not available. So what's not available? Testosterone for women is not available.
Mine is compounded. Yeah.
Exactly. You have to compound that at this point until God knows what somebody comes up with it and get its FDA approved. So what does FDA approved mean? It means that every pill, every patch has to have exactly that amount of medicine. It has been checked. Compounded, there's no one over checking that. They could give you something totally different than what I gave you. So it's very hard to navigate increasing and decreasing that.
Mm-hmm.
So you got to really go to a compounded pharmacy that you trust. Now, why? Because there are these compounded pharmacies that what we call they're not, there's no FDA approval because there's no oversight, but there is some that are called, I don't remember the name of it, but 501s or something, where the FDA checks once a month their batches to make sure each batch is the same. So at least there's some oversight. So I prefer those, and I'm more comfortable with those. But patients who come to me with compounded medication and they say it's not working, I have to take them all off and just start from fresh because I don't know what exactly if they're getting it. So some of the studies show that it could be 3% of what they write or 300%. Like it could be just totally off. I know it's a tough market out there, and it's really hard. People sell their own hormone compounded. I don't believe in that either. Because again,
don't use these. There's all this marketing.
Oh gosh,
for these supplements that you can take, and just listeners, please just go to a doctor. Go to a doctor. That's why doctors are here. They've gone to school. I hate to cut us short, but because we've been gone so long, I know that this information helps me. I know that my listeners, some of my top episodes have been my episodes about aging and hormones. I think this is really important stuff. Like I said, if you are struggling and you're told you have to have a hysterectomy, it changed my life for the better. So please reach out to me. I'm happy to answer any questions for you. Dr. Shah, how can people find you?
Well, my practice is called Empower Her Health Center. So it's empowerherhealthcenter.com. And that'll give you my phone number and address. I'm in Manhattan Beach. 2 takeaways: get second opinions, get third opinions. It doesn't matter what the doctor thinks. Think about your body. Most important. That's number 1. And number 2, don't settle. If you get something, a hormone replacement, and you're not feeling good, that means it's not the right dose. It doesn't mean hormone replacement doesn't work on you. So just be your own advocate in this crazy medical system and just get more opinions. It's okay.
And if you are local to LA, I say this all the time for therapists, by the way, if you're struggling with depression or all these things, why I do the podcast, it's like dating. Yeah. So if you're having struggles with perimenopause or menopause, I promise you there's hope. Listen to me, there truly, truly is. And date around. Like you're on a dating app. Go see another doctor. Like she said, get a second opinion. I found my special doctor after all. I'm just so happy. I feel so great. Thank you so much, Dr. Shah. And everyone,
trust your instincts. That's the other one.
Trust your instincts.
Trust your instincts.
Everyone, keep going. You matter. Your story matters. Thank you so much.
Thank you.
Judging Meghan with Meghan Judge.